So you really may need to do the surgery to get adequate access. And I can tell you that even if we do the surgical procedure, and even if you have the loops, and even if you do whatever you can to clean this, it is not easy. And it is more difficult if we are unable to remove the superstructure. So at least if we can remove the superstructure, we have some advantage, and we have a possibility to be able to look around. But please look at this one here. You have mineralized deposits here in this region, and it is very, very difficult to remove it. So now we should, I just would like to show you a case with gingival grafting. This is when we feel we don't have adequate soft tissue. So if we are in that situation, we can decide to make a soft tissue adjustment. This is a patient who has difficulties in cleaning this area, and we have frenula attaching at both of the implants. We have lost, about in the middle one, half of the bone level around the implant, but even here we have lost a couple of threads on both the mesial and distal one. In this case, we wanted to improve the soft tissue around this area, and to do that in those non-aesthetic areas, the easiest way and most predictable way to do it is to use one of those epithelialized grafts, a free gingival graft, and put it down there, because even if you have some shrinkage, it will give you adequate soft tissue in the area. After doing that, we normally place, very conventional co-pack in the area, and you see what this is the end result. And of course, it's much easier for the patient to obtain a good oral hygiene in this region. So this is the preparatory phase where we try to, if we feel it is of advantage for the patient, we do this soft tissue management. Now, when we open up the flap and we look at the defect, we can try to categorize the defects into different morphologies. So we have tried to depict in this slide just the different ones. So we have the four-wall defect or circumferential defect that completely encompasses the implant, so you get 360 degrees all around. This is more like a container, and we feel, although, and I would like to stress that, there are no really good scientific advice or claims that those are good candidates for regenerative therapy. We, from a clinical perspective, in many cases, when it looks like that, we would prefer to do a regenerative therapy in these areas. We would also, in many cases, prefer to do a regenerative approach if we have the three-wall defect or the dehiscence type defect. In those areas, we may combine the use of a bone augmentation material with the use of a buccal membrane that you may have to pin to be able to sit there and really keep your bone augmentation material over the dehiscent type of defect on the buccal side. And you may ask, couldn't we have dehiscence on the lingual? Yes, we can, but it is not very common. I would say that in my practice, at least 85 to 90% of all the dehiscences I've seen are located on the buccal side. So, but for us then, for Jean-Louis and myself, we would, in those cases, we would most likely try to do regenerative therapy. If we have those type of clinical situations that we would say is a two-wall defect, or twin peaks, as you can also maybe say, where you have adhesions both on the buccal and then on the lingual side, you have only walls on the mesial and distal. In many cases, we would prefer to do a resective approach. However, as you saw just a couple of, maybe 30, 40 minutes ago, if you have a tooth adjacent to this, you cannot do the resection. So you have to take into account from each and every clinical situation how to handle it. The same goes for the one wall. But, in most cases, I would say those will be done with some kind of resective therapy and apically positioned flap to handle it, to maneuver it. So these are the typical two-wall defect where you have it like this, and you can say, okay, would you treat that or would you extract it? I think maybe in many cases the best way to handle the periimplantitis in this clinical situation is removal of that implant and just keep those two. I think this is the easiest way to solve the problem. Yeah. This way is a typical one-wall defect. You have one wall here, you have one wall there. This is not very easy, but if you have a distance to the next implant, I would prefer to do a resective approach and make an apical position flap so that the patient can clean that area properly. So apical position flap is often used in those situations, and also when we are in the non-aesthetic zone, because I think you agree with me that doing apically positioned flaps in the aesthetic area in patients, especially with a high lip line, is a complete catastrophe. Then we have to try to maneuver that as the best we can. But this is just an example. We have periimplantitis in the lower front area. We do a resective approach, apically position the flap, and of course we will expose much more of the implants, but it is now possible for the patient to clean the area. On the contrary, if we now look here, this is another situation where we also are using a pocket reduction approach. We have a deep defect like this. We open up and we can take a little bit off here, but on the mesial it's also possible to do some resection. There is no buccal wall at all. So we make some type of remodeling using just a diamond burr. We clean, as you can see, even the implant chemically, and the chemical we are using is 3% hydrogen peroxide. Other cleaning materials or substances could be used, and there is really, in the literature, there is no material or no substance that really is proven to be better than the other one. We have used in our clinic for more than 20 years 3% hydrogen peroxide, and as long as we cannot find something that is really improving the results or shown to improve the results, we will continue to use that material. So after suturing, when we do apically positioned flap, we really try to keep the flap apically positioned, and we do that by using a surgical pack just to allow the flap to be apically positioned. And now you have a reduction in the probing depth, and it's possible for the patient to clean. In these type of defects, as we discussed, where you have 4-wall defects or what we call a 3-wall defect, the circumferential one, or the 3 wall with the buccal dehiscence, we can consider then doing some kind of regenerative approach. And when we do the regenerative approach, it is important, as we discussed before, not to overfill the defect, because if we get a lot of bone augmentation material coronal to the defect, it may be incorporated in the soft tissue and may just act as a foreign body. So I would recommend us to just keep the augmentation material within the defect, and if we have it on the buccal dehiscence, consider to use a membrane that you may have to just attach with some pins to the bone, just to protect the bone augmentation material from the soft tissues. Oh, okay, maybe you saw here, this is just to show you an example. This is a nice container like that, and in this case we used BioAS and BioAS, so now it looks good, but I cannot say that, of course I cannot say that this is reosteointegration or something like it. It's defect fill. It's defect fill combined with shallow probing depth, no bleeding, and so far I have to be happy, you know. And if it stays like that, this is for me considered to be a good treatment outcome. But I cannot claim that we have accomplished a reosteointegration, of course not. Just a few mention a little bit about reosteointegration, because the question is, of course, is this possible? Can we really get reosteointegration? And we did a couple of years ago, together with the EAO, a review, and my colleagues at Dublin Dental Hospital. We looked at everything that was published up to then on reosteointegration on implants, and the data was clear. It is possible in the animal to obtain reosteointegration on a previously contaminated implant surface after therapy. So the possibility is there. This is no doubt. You see also the second bullet point, that implant surface characterization may influence the degree of osseointegration. And it works, you know, the same way. If we have a rougher implant, it will heal better. So even if during the disease it may be more difficult to treat, but if we can possibly treat it, we will get the rough surface, and the rough surface seems to be more advantageous to get reosteointegration. But as you see here, there were no really good method, that predictably could say that if you do like this, you will get reosteointegration. But this is all in animals. But does it work in the human? And so far, to my knowledge, there is only this one case presented in the literature, and it's the case is from Kaspar Wolfrath in Oslo. I got the slides from him. What they did, they had advanced periimplantitis in the maxillary, front region. This is a radiograph. They removed the superstructure and they clean out the defect. In this specific case, they used titanium granules. Those are granules that are like a sponge, more or less. So they consist of about 80% air, and the rest is titanium. And the reason is that now the bone is going to grow not only on the outside, but also inside those granules. So you are going to have more bone in the area. So they use this, and this is the radiograph after application of the granules in the defect. And they then had one small problem. Everything healed nicely, and they were going to replace the superstructure, but they couldn't find the spare parts. So they couldn't put a new superstructure in place. So they had to find out the implant that they so carefully treated and put a new implant in. And since they now had to train out the implant, they could do microradiography, and they could make histology and whatever you want, since you had it. And doing that, they showed this is the microradiography, and this is the histology, where you have the implant surface eye, newly formed bone here, and you have the PTG, or the titanium granules here. So of course this could be at least a case demonstrating that there is a biologic possibility to maybe obtain reosteointegration even in humans following therapy of periimplantitis. This is the way at present we try to treat when we do the surgical procedures. We of course expose the implant surface. We remove the granulation tissue or granulomatous tissue from the area. Sometimes it could be difficult because in some instances you have a very narrow defect, and the way we are used with the materials we have available, it is difficult to get around the implant. We are using routinely now this type of brush. It's a titanium brush. It both have some effect on the surface, but it also removes further down the infected tissue, and it is made of titanium. So this is the mechanical type of therapy we use. Then we use, as we discussed before, chemical therapy of the implant surface. 3% hydrogen peroxide for 1 minute. We interchange the whole time, so we get new fresh one. And then we rinse thoroughly with saline for about 1 minute to take out all excess of hydrogen peroxide. And then we decide if there is a defect, a good container, and then if so, we are using some type of bone augmentation material. Preferably, we are using non-resorbable type of materials. So the ones we normally, basically there are a couple of ones we use. We use the titanium granules, we use the BioOs, and those are the two most frequent ones. We also sometimes use the FreaOs, the previously called Algipore. All those three we consider non-resorbable, and we want a non-resorbable material to keep up the soft tissue. I cannot tell you that this is really what we should do, but we have one study that I will show you later where we have compared the use of BioOs and the use of autogenous bone, and the results with the non-resorbable material is better than if we use the patient's own bone, and probably it's because the patient's own bone will be resorbed more quickly, so we will not get the defect fill in the same way. This is just a treatment modality. This is show you this case, and we will have a short break. So here we have a defect, as you can see, both clinically here, and you can see it on the radiograph there. In this specific case, we were using this type of safe scraper, I think you are familiar with it. And this is now to take some of the patient's own bone, and we do that, we put it in the defect. Here, in this specific case, we we're also using an air abrasive device to further clean the surface before placing the bone. And here you can now see the results. These are the results following healing. And we have some defect fill, and we have some recession. And if we can keep this result, I think we have to be quite happy. But as I told you before, the patient needs to come on frequent recalls.